Good morning. This is Senate Health and Welfare Committee. It is January 28th, and today we're going to continue a look at S91 and talking with Miranda Gray from Agency of Human Services and the Child Development Division. And then we'll also, if we have some time, we're going to go through two bills, just look at two bills that have been introduced, one by Senator Hooker, one by myself. And we'll take a minute to look at some of the budget adjustment language that Sarah Clark sent to us. And Nolan is here and Katie is here. I don't know whether we'll have support going through that language, but at least we'll look at it and then we can decide how to proceed. Perhaps come back to it next week. So those are the things that we're doing. And good morning, everyone. Glad you're here. So our first item on the agenda is S91, and we are very lucky and fortunate to have Miranda Gray, Interim Deputy Commissioner of the Child Development Division, with us. Miranda, why don't you introduce yourself for the record, and then we'll listen to your testimony.
Thank you. Good morning. For the record, my name is Miranda Gray. I'm the Interim Deputy Commissioner for the Child Development Division. I appreciate the time you've afforded me this morning with you to talk about the S91 bill. So a group of my colleagues and I did meet with the Parent-Child Center leaders, I guess it was 2 weeks ago, maybe a week and a half, to discuss the bill and just to get some clarification where we had questions. I have some minor language suggestions that I'm happy to share if the committee would like, but just wanted to, sorry, go ahead.
No, go ahead. Do you, will you be sharing your screen and putting the bill up, or do you have your testimony in writing? Because I don't see it here.
Yeah, no, I'm happy to share my screen. I can do that for you.
I mean, as long as you're going to be making suggestions going through the bill, we may as well look at it with you.
Okay. Yeah, no, happy to do that. Okay. And then, sorry, just making sure I get the bill up here for you. And then, but did just want to start with the administration does not support the section 2, which is the appropriation. This isn't a part of the FY23 budget. So just wanted to kind of start there because the other language changes that we have are pretty minor.
Okay.
All right. I'm sorry, I will just take me a
That's
moment.
Okay, take your time.
I believe.
Why don't we look at your minor suggestions and then we'll come back out to the full screen with everyone.
Did I share my screen successfully?
Not yet.
No. Okay. Sorry, I will try again.
Do we have a version of the draft that I think Katie was going to do a strike all, and do we have that?
Yes, it's right there on our page. Are you, and that's a good question. Thank you, Senator Hardy. Our
I see
Deputy or Commissioner, are you looking at the strike all amendment draft 1.1 for S90? Yes. You are. Okay, that's good. Yeah. Thank you.
You're welcome. And I will try again. I apologize. I'm not familiar with Zoom as well. Okay. I think
it's coming up. Yep, there it is. Very good.
Okay. So we have no language suggestions until page 3. So I will scroll. So the first suggestion that we have is really including language. This is some suggested language, but also talking about, because we talked about how parent-child centers could be added, but we didn't include any language about how a parent-child center could lose their designation. So just wanting to include that as well. Through my conversations, it was my understanding that could go both ways. And is it large enough?
It would be helpful for you to just to read it.
Absolutely. So what we added was a parent-child center may also lose their designation for failure to meet performance measures as set forth in the agreement, or if the needs of the community have evolved and another entity would be better prepared to meet those needs.
Okay.
That was the top of page 3.
And so just to understand the proposals that you have here, the changes, are these changes that have been agreed to between you folks and the Parent-Child Center Network?
I wouldn't
Okay.
say.
Okay, these are your recommendations. That's all.
Right.
All right, good.
Thank you. So now I will move to page, no changes on page 4. And it might be, I apologize, I think when we did some formatting, it might have added some space. So then in the middle of page 5, starting really, so with line 8, it says a designated parent-child center shall provide either, and what we've included was either directly or indirectly through formal community partnerships, the following 8 core services. So just wanting to put some more structure around understanding how, because it is done through our conversations with the Parent-Child Center, some of the examples that they had given of, maybe they make childcare referrals, but that is done differently. So just wanting to understand and have a formal relationship if they don't provide those services themselves, that they work with an entity to do that.
Okay.
All right, and then I will scroll again. Some very minor changes here on page 6, just adding in designee after where it says Agency of Human Services on line 9. And then on line 11, the Secretary's designee. It's my understanding that the Parent-Child Centers were not looking to move away from working with the Child Development Division. So just wanting to make sure that that's acknowledged in the bill.
Okay.
And I believe the yellow highlights are language that had been put in through the committee. So I don't have, and then Julie, as I said, just our last is this, the section 2, the appropriation. We don't have any language suggestions, just that the administration doesn't support this aspect of the bill.
Okay. Thank you. Okay, so why don't you unshare? Very good. Questions committee. I have a number of questions that I'd like to ask, and then, but let me open it up to the rest of the committee first. Okay. So I guess the question of compliance or recommendations, compliance, and the role that AHS plays. So are there other grants and recommendations? How many grants does the AHS have with parent-child centers? Are they all through CDD, or are there other parts of the agency that would provide some oversight to parent-child centers?
That is a good question that I would want to double check myself, just to make sure that I'm trying to reflect on my previous experience, but I think that probably the best course of action would for me to go back and to ask, just to make sure that I don't miss if they are providing certain services for other entities. None come to mind quickly, but I know that they do provide certain services.
Yeah, and I was thinking, I was also thinking of building Bright Futures, and any connection there. Perhaps Morgan Crossman would be helpful with that. And I know that, for example, Head Start reports to Bright Futures. So there's some reporting and data analysis. So it does currently, do the parent-child centers have any responsibility for reporting in on their work? Just thinking about accountability. Any reviews?
They do, for us, the grant agreements that we have in place, there are accountability measures performance measures. So we do have those. I'm not certain to BBF, but it does say in our agreements that they should participate actively in their regional Building Great Future meetings.
Okay.
But I think you're right, Dr. Crossman would be best suited to tell you if there's anything specific there.
Okay, that's helpful. Nolan, I saw your hand up. So I'm
Sure.
reaching it. Go
For
ahead.
the record, Nolan Langwell, the Joint Fiscal Office. I also know I recently got a sheet from DCF that shows the amount of money they get from other areas. So in addition to the 3.3 that they get from the master grant, there's another 3.5 that they receive through Reach Up Case Management. There's another 3.1 million that they get for family services, another 1.5 that they get from OEO. So in the DCF based budget, there is 11.5 million in the base budget.
Okay, so it's all through DCF.
Yeah.
Okay, so that right now, I think the language that we have indicates CDD. So I'm just trying to get some information. So as we go through the bill for markup ourselves, we have a clearer understanding of the current situation. So that's very helpful. Okay. Then, okay. Then another question I have is regarding geographic coverage in the state for parent-child centers. If we had a new parent-child center coming into the state, does your department or does the agency look at distribution and need? Would you look at? I'm trying to figure out if there's a new parent-child center being established. It could be right next door to another one, or it could be in a rural area that doesn't have one. How do you deal with the geographic distribution of those services, or how would you?
Currently, the way the process works is that we put out all of this, the need for the service through the procurement process. So if there was a new entity that would like to become a parent-child center, they would put in a bid during that time when they were open for procurement. So that would be how someone who would be added.
Okay.
Through the state.
So, but the bidding goes to who's sending it? It could be any one or more department. I mean, it could be Reach Up, it could be, right? It could be any one of the sections of DCF or other part of AHS. How would that request for a new parent-child center be handled within AHS?
So I believe, and I am happy to follow up to make sure that I'm giving you correct information.
Yeah, no, I thought of these questions after, and I probably should have been able to send those in ahead of time, but that doesn't always happen. Go ahead.
That is fine. I think so. The concrete supports that we were talking about, the parent-child centers delivering currently, that agreement is held by the Child Development Division. Other entities, other divisions within the department contract with the parent-child centers for other specific services. So there isn't a master agreement, per se, that would include all the services that the parent-child centers provide for DCF. So each service need, so like if economic services had something that they specifically were looking to have done, they would put out a bid, of which the parent-child centers could do. But if somebody was looking to be designated like a parent-child center and receive funding from the state, then that would be through the current Child Development Division procurement process. And I speak to this just knowing like there was 15 parent-child centers. However, when I worked for economic services, we didn't contract with all of them for case management and Reach Up. Some of them did not provide that service, but they were still a parent-child center and work with this Child Development Division. Does that help?
Oh yeah, no, that's very good. So it depends on what the parent-child center is offering, but I'm just thinking overall, it's kind of if you live in a rural area and you don't have access to a parent-child center, and there are some services offered 40 miles away, you're probably not going to drive to them. So how would that be coordinated if a new center were going to open? That's all. So just thinking about that coordinated process. Okay, Senator Hardy, go ahead.
Thank you, Madam Chair. I guess my opinion is that we don't want to complicate the process too much. There are already lots of processes that grantees to AHS have to go through, and presumably this wouldn't change them. There are accountability measures embedded in most of the grants, I would assume. And I couldn't quite see all the language on the screen that you presented, Ms. Gray, but overall it seemed fairly reasonable to me, except for, of course, the appropriation, but I understand you have to take that position. I would just like to get the parent-child centers in here to just make sure that they're okay with those changes. And I think that we should be ready to move this bill forward. This bill has been around for a really long time. CDD has weighed in many, many times on it throughout the process. And it seems to me that we should be able to make it, move it forward as soon as possible. So I appreciate your input, Ms. Gray. Thank you.
Okay. The other question that I have is related to accountability and how right now, I think in the bill, it's a peer review process. And I guess ask the question if there are other review processes that might support, or accountability measures that might support parent-child centers.
So in the current agreement that we have the performance measures as outlined, and didn't include language here because those can need to change depending on what it is specifically that we are looking for. But I'm happy to share with you what those performance measures currently look like, how we're holding partners accountable, and parent-child centers just being one of those partners.
Okay. Is there any annual report that the network provides to you or to the agency? We're going to bring parent-child centers in to ask the same questions, but I'm just trying to open up the discussion. I'm hoping that they're listening and they'll be able to bring in their perspective. Go ahead.
Of course. Yeah, so that is part of they do have a part of the performance measures are deliverables that they need to provide to the state, but whether it is a full written report, I would need to get back to you. Okay. But as you said, I'm sure the parent-child centers would be able to tell you off the top of their head.
Oh, yes. Okay, thank you. Any other questions for Deputy Interim Commissioner, Miranda Gray? Any other questions? Okay. Thank you for coming in. We have your suggested changes and we'll go through those with our Ledge Council, and we'll have additional testimony from, we may invite Morgan Crossman in from Bright Futures, because that's been brought to my attention as a place where parent-child centers may want to have a bigger role to play. And then we'll also be having the parent-child center network in again, and then we'll be marking the bill up because it is a bill that we are very interested in. But appreciate very much your taking the time to go through it.
Yes, thank you for having me. I appreciate it.
Terrific. All right, I'm going to try to find my agenda again, committee, but Katie, are you here?
I am.
Terrific, because we haven't actually gone through the new draft together. And I'm wondering if you could go through the draft with us briefly, the newest and latest, strike all, and then we'll obviously section 2 is going to be a big deal. It's a lot of money, but we'll have a chance to talk about this as we hear from parent-child centers and as we finish our markup on the bill. So let's go through the draft.
Okay. So I've Katie McGlynn, Office of Legislative Counsel. I've pulled it up on your screen. And if you remember, you've already seen all of these changes as instances of amendments. So now it's integrated into a strike haul, and the changes are highlighted so that they're easy to see. So the first change was the addition of a definition for concrete supports to mean community services and resources to address the immediate needs of family or contribute to the long-term well-being of the family or both. The next change. Okay. There was an updated section to determine the annual inflation factor. So this new language is that in determining the annual appropriation for the network, the secretary may employ an annual inflation factor. And remember, there was a discussion of whether this should be a may or shall. So may employ an inflation factor using the employment cost index for total compensation for private industry workers in New England as published by the U.S. Bureau of Labor Statistics for the 12-month period ending in September of the most recent calendar year. And then there was updated appropriation language for this coming fiscal year. 1.5 million is a appropriation shall be added to the existing base of 3.35 for a total base appropriation of 4.85 million to be appropriated to AHS for distribution to the network. And in addition, this coming fiscal year, 3.7 million in one-time funding is appropriated to AHS for distribution to the network. And then the last little change was updating the effective date.
Okay, so this doesn't include the language that Miranda Gray brought to us.
It does not, no.
Okay, so you can, why don't you take it down? I might, and then we want to hear from Nolan on a fiscal note for this, but before we get there, committee thoughts about including the language that Miranda Gray has provided to us, with the exception of section 2, which I don't think anyone wants to take out at this time. I mean, go ahead, Ruth, Senator Hardy, go ahead.
I couldn't see it fully because
Yes, I know it's
she hadn't
hard.
provided it beforehand. It was really small on the screen. So I guess I would like, did she send it in, Erin? Is it up on our site now?
I have not received anything.
Okay, so
Okay.
we need to get that, and then we'll put that up, and we will ask the parent-child centers to come in and to comment on that language and see how we feel about it after we've heard from them. So we won't integrate it at this time, Katie.
And
Okay.
just to, sorry, go ahead.
Senator Cummings and then Senator Hardy. You're muted, Senator.
You can hear my clock strike. Have we got, this is a lot of money. It's going to give us trouble in approps. And if it makes it through, it'll probably get it vetoed. But have we heard why they need this money or what they're going to do with it?
I think we heard some initial testimony on that, and that's one of the reasons, one of the important reasons why we need to have them back in to justify the section 2.
I mean, a
So,
$1.5 million in one-time money, I think we need to know what they're going to do with it.
right. I think they did provide some testimony on that, and we'll have them come in and reinforce what their request is. Okay, we'll do that. Did you have a question or a comment, Senator Hardy?
It was just a couple things. One was they do have individual parent-child centers have annual reports.
Right.
And the network is working on a network annual report for all of them.
Yes, I do know that, but I wanted to see what the response was from the agency, from the department. So, yeah, but you're absolutely right. Thank you
Okay.
for
And then in
reminding
terms
us.
of the funding, the 3.7 million is one-time funding, and that's what they received last year in one-time funding.
Right.
And that a lot of that was, pandemic related
Infrastructure. There was some
response.
capital expenses in that. I think when we have them in, we'll have to ask how that 3.7 was utilized last time.
Well, I
And
can
we'll,
that.
yeah.
In the budget last year, the specific language was 3.7 million to the Department for Children and Families, which I was going to suggest to Katie instead of AHS, it should go to DCF. For one-time grants to parent-child centers for capital and program improvements. That was the exact language. So the question is whether you want to have language that specific again, or you want to leave it as currently, which just says 3.7 one time.
I think we'll have to wait and hear from folks, parent-child
Okay.
centers. I don't
Because
want
that's what the one time was for last year. So I assume
Yeah, I do
again.
remember they had some some capital needs that they were needing the money for. And so what we'll do is we'll ask them to come in and just share with us what they did with that money briefly. And I know they've provided written information previously, but we'll hear again, and then we'll listen to their comments on some of the other questions that we have.
Okay. I have one more language suggestion, but I can wait. It's up to
Oh,
you.
no, what is it? Go.
So as I got more information, they have a lot of different funding in base budget. And the language says existing base 3.35. So maybe we want to be clear, say it should be added to the existing master grant or something about the master grant, right? Because that's
Yes,
the 3.35. So I thought you might want to be a little more specific because that's where it is now. And that's where you want to be specific that it goes. That's
so those the changes that you've just, or that change in particular, Katie, we could ask Katie to put that in at this point.
yeah. The other one, I think the money should still go to DCF. You can decide later whether it's capital or program improvements, but right now it says AHS. I think it should be DCF.
Yeah, both those probably work. Do you have a specific fiscal note for the bill at this point?
I mean, I have a working fiscal note, but I'm not going to
No, you don't have to.
share it until you
Nope.
pass. But basically, it just says, which we just talked about, 1.5 million to be added to the big, to the existing base budget, and 3.7 one time. That's what it would say.
Okay.
Oh, and then I have something about the inflationary factor, but we changed that
For the workforce. Yeah. How do
we
you
changed it to
calculate?
but then we change it to a May, or is it still?
It's a
shall?
May. It's a
Okay.
May.
And it's
Katie, what else? What else do we need to hear here?
That's it for me. If it's okay with the committee, I might follow up with Miranda. I had a few questions to better understand the language she was proposing. So I might try to do that so I have a better handle on some of the proposals.
Okay.
But other than that, I'll just make Nolan's 2 changes and send you a clean amendment with those 2 changes, and I won't make any other changes until you've heard again from the parent-child centers.
Very good. So we will reach out to the parent-child centers and we'll put this. Aaron, can you remind me, do we have this on our agenda on Tuesday? I'm trying to remember.
Tuesday morning, first thing.
Tuesday morning, first thing. Can you reach out to Amy? I believe it's Amy Schollenberger, and we'll communicate with her that we'd like to have her come in.
Okay, will do. You want
That
anyone
would be good if she's available. I hope she's available.
else? Okay.
And I'm happy to talk with her if that's needed. Okay. All right. Anything else, committee, on S91? All right. I mean, there's a big step in the bill to have the parent-child center network be in charge of all the parent-child centers for their peer review process, following national standards, and their accountability. And the question is, with so many different state contracts or grants, do we in any way think there should be some consolidated report by the whole network to one spot in the agency? And that's why I brought up Bright Futures, simply because they get the similar kind of report from Head Start. Or are we satisfied with the current reporting grant by grant within individual departments? So that's, those are some of the questions I ask. And we'll talk with the parent-child centers and get their thoughts. And we will hear back from Miranda, I think, on some of this. So that will be helpful. Okay. Any other comments? I know we're all anxious to move this forward. I have no doubts about that. When we worked on it last time, I'm trying to remember when we worked on it last time, it was 2 sessions ago, I think. So we've got to keep moving forward. Senator Hooker.
Just a thought about the whole concept of the network and the report. I think that, and hearing from the parent-child centers will certainly shed light on it, but the idea that we should have in one place a sense of what's happening throughout the network. So it seems that all of those grant proposals and, the reports on them should be in a place where we can go to and say, are these working together? Are they working at cross purposes? So.
Yeah, that was my thinking. And without making it a burdensome process and just having whatever data is possible for understanding what's going on. Senator Cummings.
I've still got some unease. We are giving a lot of power to kind of an unofficial group, they've formed. I understand that speaking together will give them greater negotiating power with the state, but it also gives them power over other parent-child centers. They're going to be distributing the money. They're going to decide if you are a parent-child center. They're going to decide who's in and who's out. And I understand why that's a good thing from the point of view of the people who are in now. But not all parent-child centers are providing the same services. There's a base thing, but not everybody did the case management. Not everybody. We're changing the system. And what are we going to lose in this? What happens to that small parent-child center that doesn't have the staffing to do the case management, that doesn't, are they going to still negotiate with the state, or is all power being given to this somewhat informal group? And do we require that they have bylaws, that they have?
Senator, I think, these are the questions that the Parent-Child Center did address somewhat, but we'll have, when they come back in, we can ask the questions again. They do meet national standards and, so there are professional
Is any
standards.
of this in writing? Do they have a set of bylaws and a mission statement and all of those other things? And it would be helpful to see those.
Okay. I mean, we'll ask them for that as well. And the concerns that you have are probably legitimate concerns, but we need to understand what the rules are going to be in place for parent-child centers, because I mean, it's my understanding that they do an exceptional work for our state and for people in the
I'm
state.
not questioning that
No,
they do
and that we
exceptional
don't want
work.
that to change. That's all. That we do
Yeah,
not
I
want that.
just want to know what kind of controls are going with what's asked for is an exceptionally large amount of money. What kind of, what's the state or children really going to get? What's going to change for the
Right.
kids on the ground?
Okay. Senator Hardy, go ahead.
So I just want to remind everybody that most of these parent-child centers have been around for decades. The original one started in Middlebury almost 40 years ago. And
Ruth, my daughter went to the original one here and she's 40 some odd years old.
Yeah,
so
exactly.
I
They've been
know
around
that.
a long time. And I mean, I understand wanting to make sure that there's accountability and that, that it's legit. But I think it's what they're trying to establish is kind of similar to what other networks. I mean, we just looked at a bill on Wednesday about peer respite centers, which is, they're trying to establish a network and they're brand new. And that bill is actually providing them with a lot of internal oversight. And the DAs and the SSAs are also, they're community organization, nonprofit organizations that are part of a network. And being part of a network actually provides more accountability and support for the ones that may be struggling. And so that the ones that are maybe a little bit more established and have more experience would be able to help support the ones that are maybe struggling a little bit more. So I think if anything, enabling the network will ensure higher quality, will ensure a greater accountability, and ensure that there is this entity that the state can go to and say there's an issue with X, Y, or Z, and they can work on it, similar to these other organizations. So
I think you've made a great argument for parent-child centers overall and for the bill in particular. And I think the questions that we're asking are to ensure that accountability is in place, and any kind of data or analysis, that we could get. And we'll have to hear from parent-child centers and we'll ask them these questions. And maybe it's as simple as a uniform report from the network.
Yeah.
And that's
And
it.
just for the record, the DAs, SSAs, and I didn't hear anything from the peer support folks that said they got to decide who was in, who was out, whether or not there could be more designated agencies.
Right.
This is giving a lot of power to a very small group of people. And I just want to I know I got in trouble for saying guardrails last time, but I want to make sure it works.
Okay. So as we're thinking this through, Senator, and we bring folks in, it's important to ask these questions and ensure that we do have the language in place that is appropriate. My concern is that we'd like to see an even distribution to meet the needs across the state. I think of the CON process for some of the clinics and hospitals that we spread across the state to ensure that there are services available. We don't want to lose sight of having some oversight. That's all. Any other questions or comments, committee? All right, so we will bring the parent-child centers in, and we'll look for Miranda Gray's testimony if it comes in written form. Otherwise, we have just the bill from her, but she will have hopefully some responses to the questions that we've asked. Well, I think it's important for us to ask the hard questions. No one wants to hold parent-child centers back, but we are responsible for asking the difficult question and getting the difficult answers. Okay, So Jen is here. Good morning. Jen, I'm going to ask you a question. We had the BAA Human Services language that came to us from Sarah Clark after the BAA testimony. And I asked Aaron to put that on our agenda. It doesn't have to be right where it is. You're not the one to go through that with us, I understand.
Not if it, I mean, if it's something
I
from
think
Sarah
it's-
Clark.
It is, and it would be either Nolan or Sarah. And it was this morning because we had a cancellation from David Englander. So I was just trying to put something in that we could look at together. But
Yeah, I don't think I'm going to be the one to do that because I'm not
no, I
going
don't think so. And I think Katie
to notice,
has
but let me
left.
just look at it. So is this looking at the language as it passed?
Yes,
Which piece of it is this?
it's under Sarah's name. It's
Okay, yeah, I'm
who-
looking at, there's two things under Sarah's name.
The
I mean,
second
some
one.
of this, some of the language stuff, Katie and I probably drafted. But it looks like a lot of it is numbers.
It is. Most of it's
Yeah.
numbers.
and I
So I'm
think they
thinking,
will be
let's
in a better
hold-
place.
Yeah, let's hold off on that conversation and we'll come back to it. Should we have some time? So given that, we'll move on to S 239. Oh, good.
Great. Do you want me to put that up on the screen and walk through it?
Yes, please.
right.
Cheryl, Senator Hooker is the lead sponsor. Do you want to say a couple of words about the bill before we have Jen go through it?
Sure, and Jen will tell you the purpose, but it's to create an annual open enrollment period for Medicare. But just to set the scenario here, is currently when Vermonters turn 65 or become eligible for Medicare due to a disability and enroll in Medicare Part B, they have 6 months when they can enroll in a Medigap plan. Now, Medicare pays for 80% of the cost of their health care, but many people need that extra Medigap plan to cover the rest of the costs. And in Vermont, if a Vermonter does not buy a Medigap plan in this 6-month period, they're penalized by increase in premium costs every month for the rest of their lives. So if you enroll outside of your initial enrollment period, you could pay an extra fee every month. And at one point it was like $75. I don't know what it is now. But it also, if you enroll outside the initial enrollment period, plans can refuse to even give you that guaranteed issue of a plan. So this bill would allow Vermonters to enroll in a Medigap plan after the 6-month period without initial fees. I don't think there's a problem in Vermont with the guaranteed issue, but it does cost people more in an ongoing fee if they've been late in applying for those Medigap plans. States around us allow this open enrollment period. New York, Massachusetts, Connecticut, and Maine do that. And this would just give people that opportunity to procure a Medigap plan to help them cover their costs. It would cut down on the sometimes exorbitant costs of the Medicare medical health care for people who don't have those plans or haven't had those plans in a timely fashion. And it just lets people continue to be covered without paying an exorbitant amount beyond what their premiums would be. Also, people are exploring Medicare Part C, or Medicare Advantage plans, and this would give them a chance to sort of test out that plan and then look for another plan that is of equal or lesser value or lesser coverage if they're not satisfied with the plan they buy initially. So it's really a consumer protection bill, I think, in that it allows people to get those Medigap plans without paying extra fees because they were late in coming to that initial 6-month period. So, and Jen will explain it all to you in much better terms, I'm sure.
But that was great. Actually, I think that was a great overview of the issue and the situation and what the bill is doing. Do you want me to put the language up and we'll look at it?
Yes, please.
Okay.
Thank you, Senator Hooker.
Let me just make sure I'm putting up the right. Here we go. All right. Hopefully you can see my screen with S239 on it.
Yes, we can.
Great. And as the chair said, it's sponsored by Senator Hooker, also Senators Hardy and Lyons from this committee. And so the description is a lot of what you just heard from Senator Hooker. The language of the bill itself would add on to our existing statute on Medicare Supplemental Health Insurance Policies, which is the formal name of what is often referred to as Medigap. But it is the same thing. The Medicare Supplemental and the Medigap is the same thing. This would specify that a health insurance company, hospital or medical service corporation, or health maintenance organization, so different insurer types, offering a Medicare supplemental insurance policy shall guarantee acceptance of an individual's application for coverage during that 6-month period following the individual's 65th birthday, which, as you heard from Senator Hooker, is the federal requirement. And this is what would be different, during an annual open enrollment period that would coincide with the federal open enrollment period for Medicare Part D plans, the prescription coverage. So this would open up a new annual open enrollment period where people could sign up for a Medigap or Medicare Supplement plan after that initial 6 months from their 65th birthday. It also says that a health insurance company, hospital or medical service corporation, or health maintenance organization offering a Medicare supplemental insurance policy shall not, and this is the fee part Senator Hooker was talking about, shall not make any premium rate distinctions or charge any additional fees or penalty amounts based on an applicant's failure to enroll in a Medicare supplemental insurance policy during their initial open enrollment period when they turn 65. So it would stop that fee that otherwise can be charged when somebody enrolls after the 6 months following their 65th birthday. This would also require these various health insurance types who are offering a Medicare supplemental insurance policy to allow an enrollee to change at any time from one Medicare supplemental insurance policy to another policy offering comparable or lesser benefits. This would allow more switching from plans if somebody finds that they're on one that really doesn't suit their medical needs. They would be able to switch from one plan to another. Can't switch up, but you can switch down. And just for the committee's own information, what's in the benefits that are covered in a Medicare supplemental insurance policy are set by federal law. They're standardized plans that have to be offered, and those benefits are set by federal law. For the most part, we cannot deviate from those, although a few states have gotten waivers in the past allowing them to do something different with some of their plans. So that's the first part of the bill. The second part would direct DFR to convene a group of interested stakeholders to look at issues relating to Medicare supplemental plans, particularly relating to the availability, enrollment, and use of supplemental coverage by Medicare enrollees. And it would specify that a majority of the stakeholders must not have a financial stake in any Medicare supplemental coverage product. So it wouldn't just be the issuers, the carriers, for example, who are a majority of this work group. And it directs the stakeholder group to examine the options that are available to older Vermonters through Medicare Supplement and Medicare Advantage plans. And Medicare Advantage is what's sometimes referred to as Medicare Part C So just to confuse you all with these various names, but we're talking about Medicare Supplement or Medigap and Medicare Advantage or Medicare C, Part C. So look at the options available to older Vermonters in these plans, their affordability, and the extent to which the state can regulate or otherwise affect the options offered to Medicare beneficiaries in Vermont, including regarding the marketing of those products. Also look at the effects of annual or continuous open enrollment periods for Medicare supplemental coverage available in other states. And as Senator Hooker said, there are 4 states that have either annual or continuous open enrollment periods for Medicare supplemental. So look at the effects on those in those states, including whether they've led to adverse selection or higher rate increases or both, and the extent to which an open enrollment change for Medicare supplemental coverage would be likely to increase access to affordable coverage for eligible individuals and to reduce medical debt, because these Medicare supplemental plans provide assistance with cost sharing, out-of-pocket costs, and also protect against some catastrophic expenses, medical expenses. And then finally, whether Vermont residents are receiving accurate information about their Medicare supplement coverage options and sufficient assistance with selecting the products that are in their best interests, and if not, how best to remedy that situation. And then it would have them, the DFR, come by January 15th of next year with its findings and recommendations regarding Medicare supplemental coverage, including any recommendations for changes to Vermont law. And that would come to this committee, the Finance Committee, and House Healthcare. The act would take effect on July 1st.
Did you
Let me
go
take
mute?
this down. Nope, that was it.
Oh.
It was over, so I stopped talking.
Okay, thank you very much. All right. Questions of clarification at this point in the bill.
Senator Lyons?
Do you want to take it down first?
I wasn't
you-
sure if there were going to be
I
questions.
don't
about
know.
the
That's what
warrants,
I
if you'd
was.
want to see them.
Do you want to leave it
So,
up,
couldn't
committee?
decide.
I just wanted to say that the study group is really an important part of this bill,
Yeah.
because there are so many products out there. And I know we've heard from constituents who are really confused about what like the Medicare Advantage plans are like. So a study group to look at what's happening here, I think, is something that's very important.
We love study groups. Okay, questions for Jen on the bill? And is this a bill that you think you would like to follow up and go forward with?
I would.
Senator Terenzini?
Yeah, thanks, Senator Lyons. I like this bill a lot. Hats off to the senators who introduced it. I think it's something we should push forward. It gives a lot of protections and adds clarity to the confusion that some experience. I think it's worth us spending some time on it.
Okay, we'll get this up on the agenda, probably not next week, but maybe the week after. And what I'm thinking is, Senator Hooker, it would be helpful if you could forward a list of potential witnesses and just copy me and send it to Aaron, and then we'll sort it out as we go through the planning process. Okay, Senator Hardy.
Thank you. I just wanted to say I definitely think we should move forward. I appreciated what Senator Terenzini just said. And I mean, I think all of us have heard from constituents who are just very confused because there's been also a barrage of advertising about these Medicare supplemental insurance programs. And I think a lot of people are very confused. And I get the mail from my mother who passed away last year, and senior citizens are getting a ton of mail about these programs too. And I think it's just, I don't know if I think that's something that maybe this working group or whatever it is could look into about how do we prevent misinformation being put out there about these programs as well. It's concerning to me as constituents are writing to me very confused. So
No, that's a really good point. The Medicare, it comes out as a Medicare Advantage plan, and then in the fine print, you see this is a private
yeah,
offering. This is not Medicare, and most people won't even look at that fine print, and they'll think that the Medicare CMS is sending them something. So
exactly.
yeah,
They don't realize it's a, for-profit plan, and that they're trying to be sold something. And so that is really, really problematic.
you may have seen some ads on television the same way.
Joe
Yeah.
Namath.
Yep, I was thinking of him, Joe Namath.
Yeah, and this
Okay.
was a confusing issue, even with like retired teachers who have gone to a Medicare Advantage plan,
Yeah.
wondering if it's the same type of plan that's being advertised on TV that they're suspect of. So
Yeah.
I think it's really important that we straighten this out.
So I'm wondering if it would be helpful just to get some answers about what are Medicare Advantage plans up from DFR or.
So to be clear, this bill is mainly about Medicare supplemental plans, Medigap, not
that's
Medicare Advantage. Which isn't to say you can't explore that issue as well, and that may be something you want to hear from DFR on. But I think I just
We
want to
may
be
as
clear about
well.
what you're affecting.
I think we should.
Yeah.
Yeah. And then my other question is, so we'll do both. We'll start with the testimony from folks who are interested in the language in the bill, and then maybe we can expand a little bit to look at the Advantage plans. That's been a question. And then Senator, I'm looking at jurisdictional issues here. Is there any reason why this bill would make its way to finance?
Senator Cummings.
Looking at Senator Cummings. You're muted, Senator.
If it impacts health insurance, it should go through finance. If it puts
Right.
a study committee is fine. If it's going to have any impact on the insurance market, it should probably go through finance.
Section 1 is about the guaranteed issue and open enrollment for the Medicare supplemental plans. So those are a different part of the market than we're often talking about with the major medical, but it is certainly part of the health insurance marketplace.
So it should get looked at.
Yep. So we'll sort that out, and then there'll be places where for you to deal with that in your committee. Hope maybe either by a flyover or by taking it in. It'll be up to you. Okay. Anything else on this one? All right. Shall we move on to S-244? This is a primary care bill. Can we move on to that now, committee? You're all set with the other one? Good. All right.
Do you want me to do the walkthrough first, or do you want to speak to it, Senator Lyons?
I'm not going to speak very long on
Okay.
this. I'm going to say that we are all aware of the loss of primary care providers in our state and how urgently we need to retain primary care providers. We also understand that the reimbursement for primary care and the level of primary care within the whole healthcare system is insufficient. So this bill really is a bill that strengthens primary care. It increases the overall investment in primary care up to 12% of total care spending. It invests in collaborative mental health models, which we were talking about the other day, and sustains the Medicaid rate increases for primary care services that were established and would establish a chief primary care clinical officer or clinical officer of primary care at the Green Mountain Care Board, and which is a very timely discussion for us. And there are sections in the bill that relate to some of the work that we did on telemedicine and telehealth last year, where we put in place and allowed for the decision to be made about how to reimburse audio only during the data collection year. And the decision was made to put that data collection for audio only at 75% of the code. And what that means is that we don't have a baseline of comparison. So what this bill does is it puts in place a period of time where we look at the baseline and with the current codes and equivalent codes for clinically appropriate treatment, and then the 75%. So I know that this is stirring up a hornet's nest for some people, but frankly, you can't determine if audio only is going to work if you only look at it at one set level. So overall, the bill is an important bill for lifting up our primary care services in the state, for reinforcing and improving reimbursement, and hopefully keeping some of the workforce that we've been losing left and right. I keep hearing from everyone that our primary care services are being decimated. So, and we know how critically important primary care is for prevention. All right, so that's very general introduction. I think we're all familiar with some of the issues I've mentioned, but I wanted to reinforce those. So Jen, why don't you take us through the bill, please?
Great. All right.
And let me say one last thing. You don't see other names on the bill. I don't think, I may have sent this one out for sponsorship, but I don't remember. Anyway, we'll go ahead.
Okay, so here's the statement of purpose that describes what's in it, which is very much what you've just heard from Senator Lyons, and then I'll take you through the language. The first few sections deal with that reimbursement rate for healthcare services delivered by audio-only telephone. It would add into the insurance coverage statute a requirement that a health insurance plan provide the same reimbursement rate for services billed using equivalent procedure codes and modifiers, subject to the terms of the health insurance plan and provider contract, regardless of whether the service was provided through an in-person visit with the healthcare provider or by audio-only telephone. And this language is the same as the language that's in the telemedicine statute for services delivered by telemedicine. And that provision, that reimbursement parity for telemedicine is set to sunset at the end of 2025, as I recall. The provisions of this subdivision 1, this reimbursement parity requirement for audio-only telephone, would not apply in the event that a health insurer and healthcare provider enter into a value-based contract for healthcare services that include care delivered by audio-only telephone. Again, this is the same language that's in the telemedicine statute. This is just saying if a provider and insurer are moving out of a fee-for-service environment into value-based payments, then the reimbursement may look different, and having reimbursement parity is not necessarily appropriate. So that's section 1, putting that reimbursement parity into the statute. Section 2 makes some changes to Act 6 from last year. And this is where you had set up that audio-only telephone data collection process and a report. And that report is still to come under this bill in December of 2023. But instead of just tracking utilization in 2022 and in calendar year 2022, it would add the first quarter of calendar year 2023. And you'll see down here a little bit more. In addition to all of the other things that are supposed to be presented in that report, the department would also provide a comparison of the utilization, quality, satisfaction, and impacts on cost and access during calendar year 2022, when health insurers were only required to reimburse providers for services delivered by audio-only telephone at 75% of the reimbursement amount for the same services when delivered in person, and the first quarter of calendar year 2023, when the reimbursement would be in the same amount for in-person and audio only.
Jen,
So
just to,
it's-
yeah, sorry to interrupt you, but just to clarify, they're going back up to the first section on a health insurance plan, that section, that sunsets in 2025.
This does not. I'm sorry for
Okay.
confusing you.
No,
the
you did. I'm
telemedicine,
sorry.
there's reimbursement parity for telemedicine,
Yep.
and that has with it a sunset date, because there had been interest in revisiting this issue. And so I just in saying that this is the same as the reimbursement parity for telemedicine, I wanted to be clear that the telemedicine language itself has its own sunset. This language does not. This language for audio only parity would take effect on January 1st, 2023, and continue, pending.
That's important
any
for us to
further
understand.
action.
Yeah.
Yeah.
Thank you. Yeah. Good. Okay.
Yes, and apologies for confusing the
No,
issue.
don't apologize.
All right, so then, as I mentioned, this would set the reimbursement parity requirement to start on January 1st, 2023. And so the report would look at data from 2022, when reimbursement was required to be only required to be at 75% of the reimbursement amount for in-person, and also include the first quarter of 2023, when that full reimbursement parity would be in effect, to see if there was any impact on all of those elements: the utilization, quality, satisfaction, and impacts on cost and access with that 100% parity. And then the third change required to follow through on these revisions is to this authority for DFR to determine the reimbursement amounts for health insurance plans that you'd set up last year. And that was going to be, DFR was going to be setting those reimbursement amounts for plan years 2022, 23, and 24. But if you make this change to reimbursement parity starting in 2023, then it would really just have been for 2022. So that's what, I'm just making some conforming changes to make that make sense. All right, so that we're moving away now from the audio only to a different piece of looking at primary care and other issues affecting providers. This is a provision on increasing primary care spending allocations. And many of you will remember that there was a report that came in a couple of years ago after work from this committee directing the Green Mountain Care Board to identify the percentage that payers spent on primary care. Sorry, I had to cough. So this would then direct each of the listed entities below to increase the percentage of total healthcare spending that they allocate to primary care using those baseline percentages determined by the Green Mountain Care Board as kind of where we're starting from. And they need to increase it by at least 1 percentage point per year until primary care comprises at least 12% of the plans or payers' overall annual healthcare spending. And the payers who would be affected by this are each health insurer with 500 or more covered lives for comprehensive major medical health insurance in the state employees health benefit plan, and health benefit plans offered to entities providing educational services. So these are the VHI, Vermont Education Health Initiative plans. Upon achieving the 12% primary care spending allocation, then the plan or payer would need to maintain or increase that percentage of healthcare spending allocated to primary care at or above 12%. So it's not just hit the 12% and call it a day, it's hit the 12% and then stay there or increase that percent. And then it specifies that the plans or payers' increased proportional spending on primary care cannot result in higher health insurance premiums, be achieved through increased fee-for-service payments to providers, or increase the plans or payers' overall healthcare expenditures. It would require on or before June 1st of each year that each entity listed in those subdivisions report to the Green Mountain Care Board the percentage of its total healthcare spending that was allocated to primary care during the previous plan year. And then by December 1st of each year for 6 years from 2023 through 2028, the Green Mountain Care Board would report to this committee, to House Healthcare, and to the Finance Committee on progress toward increasing the percentage of healthcare spending system-wide that is allocated to primary care. The next section deals with the all-payer model and Medicare agreements and increasing the primary care spending allocations. So recognizing that the state can't tell Medicare it has to increase what it spends on primary care directly, or its proportion of spending on primary care. This would say that the Green Mountain Care Board and the Agency of Human Services can only enter into a new agreement with CMS to waive provisions under Medicare law, or into a renewal or extension of an existing agreement if that agreement includes a provision requiring CMS to achieve annual increases in the percentage of total Medicare spending in Vermont that is allocated to spending on primary care services. Just looking to kind of leverage our waiver agreements with the federal government to get Medicare to increase its primary care spending allocation as well. Section 6 relates to Medicaid primary care payments, and this would say that to the greatest extent practicable, the Agency of Human Services must update and maintain its resource-based relative value scale, sometimes called RBRVS. It's the fee-for-service Medicaid fee schedule for primary care services to be 100% of the level of the Medicare physician fee schedule in effect for those services. So I'll pause with that part. So this is saying, to the greatest extent practicable, have the rates for Medicaid primary care services be the same as those for Medicare primary care services. And it would also direct the agency to implement Medicare's evaluation and management coding changes into the Medicaid program to achieve those increases in the RBRVS fee schedule for primary care clinicians and primary care codes. So this is looking for great maximum alignment with Medicare for how they handle primary care services. Then in section 7, we're now into the Green Mountain Care Board and the structure of the Green Mountain Care Board. And this would direct the board to establish the position of Chief Clinical Officer for Primary Care, who would be someone who currently practices or has recently practiced in primary care and who is licensed to practice medicine as a physician or osteopathic physician, as a naturopathic physician, a physician assistant, or advanced practice registered nurse. And this Chief Clinical Officer for Primary Care would be responsible for coordinating efforts to evaluate, monitor, and implement solutions to strengthen primary care in Vermont. Section 8 creates that position of Chief Clinical Officer for Primary Care in the Green Mountain Care Board in fiscal year 2023, and it would transfer and convert it from an existing vacant position in the executive branch. Finally, we have the effective dates. Most things would take effect on passage. The reimbursement parity for audio-only telephone would take effect on passage for Medicaid to the extent permitted under federal law, and on January 1st, 2023 for all other health insurance plans. So to align with the plan year.
Okay.
That's the language.
Questions for Jen on the language and just what's here. Go ahead, Senator Hardy.
Section 6, the increasing Medicaid primary care payments. Is this just for doctors or is it for all primary care providers? Like, would it include, I don't know, nurse practitioners and physicians assistants and all those people too?
I believe so. I think it would be important to clarify with AHS what that means. But my understanding of it is quite broadly written to primary care services. So I think to the extent that those are reimbursed in Medicare, the rates would align.
Okay, it just says physician fee schedule though, so. I was
Oh, I think
wondering
it's
if that-
just called, I think that's what it's
That's what it's
called. I see the
called, yeah.
question. I don't know. That is the name of their fee schedule. I don't know if that is exclusive to physicians. It's a
Okay.
Medicare physician fee schedule. So it's a great question and I don't know the answer, but I'll make a note.
Okay.
Good, we can get that clarified. Good question. Senator Terenzini.
Thank you. Yeah, I think that was a good question, Senator Hardy, because I think in the Rutland community, we quite frankly now have more nurse practitioners and physician's assistants than we do primary care doctors. So good catch. Just for my own clarification, right now, the current system, are we only paying the 75% for telemedicine to primary care doctors?
So this is audio only, so distinct
audio only.
from telemedicine. Telemedicine is 100%. For the audio only for this plan year, DFR has issued guidance or a bulletin or however they have dictated this, that insurers must reimburse at least 75% of the in-person rate for audio only telephone. So they didn't say only 75%, but they said at least 75%.
Well, I'm sure none of the insurance providers are jumping to pay more than the 75%.
Yeah, I don't know what they have done in practice.
Yeah, I once again, I'll just follow up with what I said on the last bill. Senator Lyons, hats off to you for this one. I think it's important. Our primary care physicians and nurse practitioners and so on are, they're struggling, and the battle is real every day in the field. And I would love to see them get reimbursed at 100%. So.
Thank you. Okay, Senator Cummings. No, Senator Cummings, we're going to win the trophy.
Oh, just for clarity, DFR set those rates because we asked them to do the investigation and determine if a telephone call where you don't do anybody's weight or blood pressure or even see them should be reimbursed. So they did that. This bill would undo what we asked them to do last year. I guess we don't like what they did. And I had another question and I've lost my train of thought. I keep hearing out there, it must be coming through my Zoom telepathic or something, that there is a Medicare or Medicaid increase in the rates to primary care physicians floating around somewhere. And just
Is it in the BAA? It's in the BAA.
It is in the BAA.
Yes, it's sort of embedded in a way you can't necessarily. There's a certain amount for rate increases, and a big part of that is primary care. There's also other provider types that get increases through that as well.
Because that's been a major issue. If you have a large proportion of your patient base is Medicaid, you can't make a financial go of it. So that may be the biggest thing we can do. Okay.
Okay. Go ahead, Senator Hardy.
Thanks. And Jen, in section, sorry, I should have had it scrolled to the right place, but where you list the, I'm sorry.
It's okay. Just take your time.
You could describe it and I'll tell you where it is.
It's on page 6, the increasing primary care spending allocations, and you list, each health insurer with 500 more, blah, blah, blah. Would we wouldn't be able to include ERISA plans in that, right?
Right. This would not include the self-funded employers. We do not regulate them and don't have authority to tell them to report.
Okay.
Go ahead. Can I follow up with that question? Or wait, I'll wait for you to finish.
No, go ahead. Go ahead.
I
have another
just remind
topic,
me.
so go
Just
ahead.
remind me of Riska. Go ahead. Go ahead.
Well, I just wanted to, reiterate what Senator Cummings just said about the audio only, and this is my big concern about this bill. is that we worked really hard to come up with a compromise that we could all live with last year on audio only. And I have some serious concerns about the provision of audio only and how it's used. And I would really like to honor the compromise that we came up with last year. It was very difficult for us to get something that we all could agree on. And several of us had concerns about audio only. And just to note, I see that Senator Terenzini's screen is off, but this is only a very small slice of the type of, and it is just by phone. and I know in practice that doctors are interpreting this differently, and patients are getting charged for things that they didn't used to get charged for. And I have had it happen to me where my primary care physician has charged me for a phone call to give me the results of a mammogram. And that is not okay and shouldn't be allowed. And, that was something that before that I would just talk to her and she would tell me the results of a mammogram. And now it's scheduling an audio only telephone appointment and charging me for it. And that's my concern. And I really feel like this is disingenuous to put forward a bill that undoes a compromise agreement that we all worked really hard for, not only in this committee, but in the House committees as well. And I am very supportive of efforts to support primary care, but I'm not supportive of efforts to undermine agreements that we made last year after really tough work with this committee and the other committees. And so I would really like the audio only stuff taken out of here so that we can honor and get the data first and then move on to what we're going to do with audio only.
Thank you, Senator, for your thoughts. So we will take testimony on this. There could be some validity to including that section in the bill. And I'll begin with that, but pointing out that if you charge 75% for every single code, and some of the audio only codes might be, the telephone calls might be a counseling call that goes on for a period of time.
Excluded.
There might be a distinction to be made between one type of call and another. That hasn't been made. That was in the legislation also to discriminate against types of calls. So we're going to have to hear testimony on that.
Yeah.
And then my final comment on that is, as a scientific experiment, if you're going to compare audio only with something and you have nothing, there's nothing before that, then you have to say, you have to have a period of time within which audio only has a different metric. So that comparative analysis becomes important. And we're going to have to hear from folks about this, whether and how it gets sorted out in the end. We don't know. I have talked with the House about this, and there are significant concerns about that 75% that was landed on. So we're not alone in our concerns legislatively, but we certainly need to consider the fact that what was happening previously is now affecting patients. There's no question about it. Completely agree with that, but it's also affecting providers. So we'll struggle through it. We'll listen to testimony and see what comes out on the other end of the sausage maker. And one other comment, there's a question, Jen, for you on the ERISA piece. Has anyone ever attempted to change our ability to influence self-insured through our waivers? Can we do that?
I mean, there is to date, there is no such thing as an ERISA waiver.
Okay.
Other than Hawaii was grandfathered in when ERISA was initially enacted in 1973 and 74. So no. I think given the stated purposes of ERISA about allowing for uniform national implementation or administration of employee benefit plans, it would be hard to see that being looked on favorably, but
okay.
I don't know.
Senator Cummings, are you weighing in on this conversation? And so
Yes.
Senator Terenzini also has his hand up.
Okay, no, I just had a comment. The closest we came to trying to do ERISA was when we were trying to do single payer.
Yes,
And we did the whole payer play, and the guarantee was we'd end up in court and
right.
no one knew what we'd do. But the other question on this is, I know several years ago, we heard from Rhode Island, who has mandated that a percentage of their insurance gets spent on primary care.
Right.
And what I'm struggling to understand that, unless we're saying right now that insurance companies are denying primary care payments in favor of cardiologist or neurologist payments, are we saying they have to pay more for primary care and less for cardiologists?
It doesn't say that.
I'm trying to figure out, how are we going to drum up more primary care business?
Right.
How does that work?
1%
Right, so I
a
think
year.
it does not specify, I mean, there are certain things it says you can't do, like just pay more, pay primary
Yeah.
care more and increase it that way. But I think some of the idea behind this in states that have done it is trying to do more upstream prevention work and get the payers more actively incentivized to be focusing on prevention and care in the right setting.
Okay.
And leveraging
yeah,
their financial interests that way.
right. And this is based on a metric that came to us from the Green Mountain Care Board. Anyway, so Senator Terenzini, you've had your hand up a long time.
Yeah, thank you. My arm's hurting. I had to walk away for a moment to answer the door, actually, when Senator Hardy was expressing some of her concerns, but I caught the tail end of it, and it sounds like we're going to take testimony, but I would also, I would not be in favor of, for example, I had to take a COVID test this morning. This afternoon, if my doctor's office calls me with the results,
You don't want to pay for it.
I would not want that to be considered a telemedicine. That's basically the cost of doing business, in my opinion. You're following up after my visit or my test. So I think that it's a good call out. I think there needs to be some better definitions as to what's considered, because I could see people really it could get very expensive for people if that phone call just cost me $125 or whatever the going rate is.
Right. So that's exactly why we'll take testimony and sort out whether or not there are any differentiation and distinctions between types of phone calls or whether it's categorical. So we'll do that.
Didn't
Not
we
a bad
leave out
question.
mental health? Wasn't mental health calls left out of that?
No,
No, it was, I thought,
There's nothing,
okay,
no, I don't believe there's anything that differentiates
know-
based on the type of service.
okay. I thought we had cut out mental health. All right.
It's possible that DFR did in theirs, I'm not sure.
That was part
yeah,
of the discussion last year, Anne, and there was concern, I think, from actually mental health providers that they didn't want to be treated differently, but that was one of the things we considered.
Yeah.
And it just is going to be deja vu all over again with this, and that's frustrating.
no, it's
No,
not. I want to clarify here. We don't have a comparative analysis. And if you don't have something to compare, you don't have a baseline. What are you comparing it with? That's why we need to hear testimony. We might end up
do.
right where we were. There's no, this is a proposal, and it's time for, thinking and looking at it and hearing from folks. So we will do that. So other questions? Okay. So let me just say that this is primary care. I don't know, we can move it forward as a separate bill, considering that Nolan's indicated to us that it's in the BAA. It's also going to be in the big bill, the budget proposal for the increase. But there's no reason why we can't take testimony and figure out the best way to do this for primary care and who's included in that. I've had several meetings with primary care folks or folks who are being reimbursed by Medicaid, who are just, shops are closing up in our state. And that includes physical therapists, it includes naturopaths, it includes docs, it includes nurses who can't survive. It includes people who have been accepted to take a position in the state and turned it down solely because of the salary that they're able to get as a result of our Medicaid reimbursement. So this, for me, we need to work on this. And I think we'll just go forward with a bill. We'll put it on our agenda. If we take pieces out and insert those pieces into our committee bill, we'll do that or not. So just some thoughts on that. Senator Hooker.
I applaud the idea of increasing payments to primary care and certainly in salaries for nurses and stuff. And I just hope that we can come up with a way to do this without really increasing the cost of healthcare. And that's the question, how do we do?
Yeah. And Jen, correct me if I'm wrong, help us out here. The language attempts to do that, but without increasing premiums. There's nothing in there about out of pocket or copay. But I mean, we can.
No, but plan design would dictate a lot of that.
Yeah. Okay. I mean, for me, primary care should be something that people can go and have at least 2 or 3 visits a year without out of pocket and copay, because it is the upstream that we need. That's my opinion. Okay. Any other questions? All right, so these are 2 good bills. I think there are hesitations about sections all along the line. We get that, but we'll try to put these up for testimony sooner or later, mostly sooner. Okay, I have to look at my agenda because I think what we have scheduled for today is oh, Aaron, yes. Good idea. Let's just take a little break. How do people feel about a break? And we're not voting.